ready.
Which is why I need to
So
do
whoever got a lot of memory, if
I
you
do.
To insert a nasogastric or NG tube, first assess the patient by auscultating for bowel sounds and palpating his abdomen for distension or pain. After preparing the equipment at the patient's bedside, raise his bed to a comfortable working height and help him into a high Fowler's position with pillows under his head and shoulders.
Just gonna fix your pillow.
Okay. Nice.
Now place a towel over the patient's chest, give him some tissues, and have him blow his
If
nose.
you would please blow your nose for me.
Okay.
If you're right-handed, stand on the patient's right side.
Here.
If you're left-handed, stand on his left side. After putting on clean gloves, instruct the patient to relax and breathe normally while closing off one nostril. Then have him repeat this with the other nostril. Plan to use the nostril with the greater airflow.
I think you have better airflow on the right side.
Yeah.
You think so?
Yeah.
Okay. Mr. Burns, I'm just gonna measure your tube placement, okay?
Next, measure the distance to insert the tube. To do this, measure from the tip of the patient's nose to his earlobe, and then to his xiphoid process. Mark this distance on the tube with tape or indelible ink. Now inspect the feeding tubes for flaws. If it has no rough or sharp edges or clogged holes, curve 4 to 6 inches of the insertion end around your index finger, and then release it. This decreases tube stiffness and aids with insertion. Using water-soluble lubricant, lubricate 3 to 4 inches of the distal end of the tube.
Mr. Burns, I'm gonna insert the NG tube in your right nostril. So if you
Explain that
begin to gag, I want you
intubation is
to
about
put
to
up your
begin,
index finger
and
just
instruct the
like that.
patient to raise his index finger if gagging or discomfort occurs.
Can you hold your head back for me? Okay.
With his neck extended back against the pillow, insert the tube through the nares with the curved end pointing down. Continue to insert the tube along the floor of the nasal passage, aiming toward the ear. If you feel resistance, apply gentle downward pressure to try to advance the tube, or try rotating it to see if it advances. Never force the tube. If resistance persists, withdraw the tube. While the patient rests, relubricate it. Then insert it into the other nares unless contraindicated. When the tube is just past the nasopharynx, rotate it toward the opposite nostril. This helps the tube curl around the corner of the nasopharynx and pass above the oropharynx.
Okay, Mr. Burns?
Uh-huh.
Pause here to let the patient relax.
I'm gonna have you drink some water.
Then provide a glass of water with a straw, unless contraindicated, and instruct him to tip his head forward and take sips of water to ease the tube insertion as you continue. With each swallow, advance the tube 1 to 2 inches. If the patient cannot have fluids, instruct him to dry swallow or suck air through the straw while you advance the tube with each swallow, and remind him to keep his head tipped forward. If the patient begins to cough, gag, or choke, withdraw the tube slightly and stop for a while. Tell him to breathe easily and sip some water or have some crushed ice. If coughing or gagging continues, inspect his oropharynx with a pen light and tongue depressor. If the tube is coiled in the back of his throat, withdraw it until its tip is back in the oropharynx. Then reinsert it while the patient swallows. After he relaxes, continue to advance the tube with swallowing until you reach the tape or mark on the tube. Temporarily tape the tube to the patient's cheek until you have verified tube placement. Follow your facility policy for verifying NG tube placement. For example, ask the patient to speak and inspect his posterior pharynx to detect a coiled tube.
You say ah, can you open it for me? I'm gonna look for your tube. Okay.
Then draw up 30 milliliters of air into a 60 milliliter catheter tip syringe and attach it to the end of the tube. Flush the tube with the air while listening over the stomach for gurgling or whooshing sounds. Do not use the blue pigtail tubing. Then gently draw back on the syringe to obtain 5 to 10 milliliters of gastric contents. Observe the aspirate in the syringe, which normally is cloudy and green, off-white, tan, or brown. Also measure the pH of the aspirate by dipping a pH strip into the fluid, or by applying a few drops of it onto the strip. Compare the color of the strip with the color on the test chart. Be aware that pH can vary. Typically, it is 1 to 4 for a patient who has fasted for at least 4 hours, 5 or higher for a patient receiving continuous tube feedings, and 6 or higher in intestinal or pleural fluid. If ordered, obtain an X-ray of the patient's chest and abdomen. If the X-ray shows improper placement, reposition it and again verify its placement. When the tube's position is verified as correct, clamp its distal end or connect it to a drainage bag or suction source. Then anchor the tube. To do this, apply tincture of benzoin to the end of the patient's nose and let it become tacky. Apply a prepared strip of tape to his nose, leaving the 2 split ends free. Carefully wrap the split ends in opposite directions around the tube. As an alternative, apply a tube fixation device using a shaped adhesive patch. Then wrap a piece of tape around the tubing and pin the tape to the patient's gown, allowing some slacks peeking from his head. Place a mark on the tube to show where it exits the nares, or measure the tube length from the nares to the connector for the drainage receptacle. The head of the bed remains elevated by at least 30 degrees unless contraindicated. Clean the nostril area with a washcloth dampened in mild soap and water. Also provide oral hygiene. As part of your follow-up care, regularly verify tube placement. Do this before each feeding or fluid or medication administration during intermittent feedings, every 4 to 12 hours, and before medication administration during continuous feedings, and at least 1 hour after medication administration by tube or mouth.